Thank you. It's really great to be here, and it's really nice to be invited to come and talk. It is true that there's no way that I know as much as Jason said I do. But it is true that I do have a wide range of experiences and interests within pharmacology and pharmacokinetics, which always then makes it hard to give a half-hour talk, because everything seems to be important. I think another thing in terms of me, my current clinical practice, is working as a nephrologist, but my main area of clinical pharmacology is clinical toxicology. So sometimes the kinetic questions that I have might be different to some of the kinetic questions that others might have. I'm aware that the group that we've got here are from a very broad range of backgrounds, both in terms of experience, but also in terms of how long they've been working in the field, but also in terms of backgrounds. Some of you have strong backgrounds in biology, others have stronger backgrounds in terms of analytical components. So I've tried to make the talk a bit broad in terms of a lot of its introductory comments in terms of what pharmacology and pharmacokinetics are, because I think that's important to build on what comes afterwards. And then when talking about pharmacokinetics in hospitals, of course I'm biased on this, but I think it's a major issue that is a real problem at the moment. So I've tried to pick up a few examples, so it's not possible to be an all-inclusive talk. So I'm going to talk just a bit about what is pharmacokinetics. The other thing, by the way, about the echo, which is important, particularly when we're talking about infections, is that it's always a time of the year when everyone gets sick in Brisbane. And so, but normally it's viral, I think, rather than bacterial. But anyway, let's give antibiotics. So we're going to talk a bit about pharmacokinetics, why it's important, and a bit about hospitals, the particular issues that we might see in hospital. Working as a nephrologist, I tend to find it difficult to differentiate hospital to community because it's a spectrum in terms of my patients between both areas of work. So some examples might cross over. And I want to talk a bit about the challenges associated with incorporating pharmacokinetics into decision making, which in itself would be a whole day in itself as a topic, because it really is very challenging. So in terms of pharmacokinetics, first of all, what's pharmacology? Well, I think we all know this. We have an input, which is a dose, something gets into the body, the drug gets in the body, things happen, we get an output. And what we want to do is we want to improve the relationship between the dose and the output, and that involves understanding all of these things that are happening within the body. And so clinical pharmacology is where we apply these factors when it comes to the treatment of patients. And so this largely comes back to what are the principles behind the prescribing process and what do we need to consider. And so the two main things that we talk about are pharmacokinetics and pharmacodynamics, which to this crowd, these terms are probably not particularly foreign and they don't induce fear in you. But when I talk to even pharmacists, particularly medical students and doctors of all levels of experience, just the mention of pharmacokinetics and pharmacodynamics, you almost see a shudder, because I think they find these concepts are complicated. And we all know that when you find a concept complicated, you probably avoid it, because you think, I'll deal with that later. And that is an issue when these are the primary factors that we consider when we're prescribing drugs. And today we're mostly talking about pharmacokinetics, and this is what the body does to the drug. And so it relates concentrations in biological fluids to biological processes. And we summarise it by ADME, absorption, distribution, metabolism, and excretion. Most of the discussion today, I think, is going to be on intravenous administration, although not in some of the tropical research, I think, in which case we talk most about distribution, metabolism, and excretion. This is different to pharmacodynamics, which is how the drug works on the body itself. And so we can map through this process whereby we can say a drug is swallowed, it needs to first get into the stomach, so there's time for that, it needs to dissolve into solution, go across the gut mucosa, usually goes through the portal system via the liver into the plasma. And from there it's in equilibrium with peripheral tissues. These may or may not be the site of action. The site of action may be in the plasma, may be peripheral, and then we get the effect. All the time while the drug's interacting between the plasma and these other tissues, it's being eliminated by the body. We can bypass these first steps if we give it intravenously. And it's these different processes that lead to the concentration time profile. So absorption phase and then the elimination phase. And some of these processes are active and some of them are passive. We know that if it's passive, it's going to be concentration dependent, but we know if it's active, it means that it may change. It can change with drug interactions. It may also change with endogenous processes, which I'll show you an example of later. So the key pharmacokinetic parameters that we think about are clearance. This reflects both metabolism and excretion, and the relative proportion of these will depend on the drug that we're talking about, volume distribution, and these are related by half-life, as you can see with that simple formula, which again induces fear in most people. they forget. But we can see that a doubling of the volume distribution will double the half-life, which means you need to give the drug less frequently. So in terms of clearance, the reason why we care about clearance is that this determines the maintenance rate. We know that clearance is composed of all of the different components that contribute to clearance. So total clearance relates to renal clearance, liver clearance, and other clearance. And for myself as a nephrologist, and those of you who work in critical care, we use a lot of dialysis, and so dialysis would be inserted as another. So the significance, for example, of dialysis on total clearance would relate to the proportion of total clearance that comes from dialysis. This is why when we're looking at drugs and we're looking at clearance related to dialysis, we also need to understand endogenous clearance in that patient so we can get an appreciation about whether or not the effect of dialysis is actually significant in that patient. And we use these if we want to use a formula by this formula dosing rate is clearance by concentration steady state. If we halve clearance and we want to keep steady state concentration the same, then we'll also halve the dosing rate. So these are directly proportional. As a nephrologist, I'm particularly interested in graphs such as this. This shows how the clearance of different drugs will change depending on the kidney function. So we can see here on the bottom, which is GFR, or glomerular filtration rate, a measure of kidney function. We can see three different patterns here which describe what happens with drugs. So if we start with drug C, as GFR decreases, there's no change in drug clearance. And this would be consistent with a drug that is purely eliminated by the liver. Certainly there's no involvement with the kidney. In contrast to drug B, where they're directly proportional, so as GFR halves, so too does drug clearance, then this would suggest that all of the drug is eliminated by the kidneys, and drug A suggests that there's a combination. And so it would be not uncommon that I'd give an exam question to our students or even physician trainees along the lines of, with one of these drugs, if the kidney function decreases by 50% or 30%, how would you change the dose? Fairly simple principles, but not well known to everyone. Volume distribution is also important. I'm going to go through a few examples about why that is. First of all, it's important to remember it's an apparent volume, it's not a real volume. It's based on giving a dose of a drug which is known, measuring the serial changes in the concentration, extrapolating back, and based on that initial concentration, the dose that was given, we can work out the volume distribution. And that looks easy and straightforward. And it tends to be fairly robust. This looks at the effect of giving a fluoroquinolone. One dose is intravenously, one dose is intramuscularly, and we can see here that both routes have the same volume distribution. And we can see differences in the concentration time profile here, depending on the process. So the top one is from intravenous administration, so you can see the time it takes to distribute around the body, and then we get into an elimination phase. In contrast, the other one is intramuscular, which relates to the time it takes for the drug to get absorbed. But in both cases, the volume distribution would be the same. But if only it was that simple. What we do see often for many drugs is that there are multiple compartments by which the drugs will distribute into. And this is actually important when it comes to considering how we dose drugs, and also what we measure and what the importance of those concentrations are. We're going to be hearing more about that later. So for example, if we look at this systematized figure, we look, drug comes in, goes into the gut, gets absorbed, and this is the central compartment or the blood. All the time there's an equilibrium with the peripheral compartment where it's going in and out and it's being eliminated. That's similar to the figure that I showed you beforehand. And this influences this distribution time curve. The rate at which it goes into this peripheral compartment will depend in part on how big is that compartment, and also depend on the rates at which it's going in there. When we're talking about changes in the concentration time profile, this is going to vary a lot depending on whether or not it's the first dose that someone's had or if you've been having chronic dosing. So for example, with gentamicin, we generally think of gentamicin as having single compartment kinetics. That's true when we give doses based on based on the current method of treating, so single doses for a short period of time. But if you have a highly sensitive assay and you measure for long enough, you can actually see that there is a second compartment. And the more doses that you give, the more significant that second compartment line is, because it gets higher. And this relates to accumulation of the drug moving from the central compartment into the peripheral compartment, so that after this drug has been eliminated, we are getting drug coming back again. And we see this a lot, particularly in my area with dialysis, where this peripheral compartment becomes very important. The rate of distribution may also, and rate of redistribution may also influence the onset and offset of the effect. So if you're treating an infection that's in a peripheral compartment, for example, subcutaneous tissues or in the brain even, then the time it takes for that antibiotic to work is the time it takes for it to get into that compartment and to accumulate to a high enough concentration. Similarly, if you're relying on treatment of bacteremia and you're giving a drug that is highly lipid soluble and distributes rapidly from the central compartment to peripheral compartments such as adipose, the concentration you'll achieve in the blood quite quickly will go very low. And in that case, you might get subtherapeutic concentrations within the central compartment. So that's an overview of pharmacokinetics. So why are they important? Well, we've already mentioned that pharmacokinetics are important for working out how we dose. There's multiple different ways of which we can dose people. If I start with Mr. John Smith, who's sitting in front of me, and Mr. John Smith has various sorts of medical conditions, what dose do I prescribe him? There's two ways that we can go with this. One is that we can start with the average dose that would be used for the average person in the population, and then we titrate up or down to achieve the effect that we want. The problem with that, average means it's average. There'll be some people you're underdosing, some people you're overdosing. You may get toxicity, you may get subtherapeutic effects. And this then, in terms of how you titrate, depends on which of these endpoints you're able to measure. When it comes to measuring antibiotics, clearly looking for treatment failure is difficult because it may take 2 to 3 days until the effect of an antibiotic is really very clear, at which point progression of infection, they've probably died from severe sepsis depending on the bacteria. So this is where looking at clinical endpoints can become tricky. Similarly, when we're looking at clinical endpoints of toxicity, it can also become confusing. If someone's got impaired kidney function, you give a drug, they get confused. We wonder, does this relate to drug accumulation toxicity? Does it relate to uremia or something related to the kidneys? The other approach, and this is what we do more so with chronic therapy outside of hospitals, is we just start at low dose and titrate up. And obviously this is going to be a problem if we're treating someone who's critically ill with sepsis in ICU. So this is where we need to be a bit smarter in terms of the better ways that we can treat people. So dose adjustment, the key points that we want to achieve by this is we want to maximise the concentration of the drug at the site where the infection is so that we can get the effect. We want to avoid subtherapeutic concentrations for obvious reasons. This promotes antimicrobial resistance and also about adverse drug reactions. And this requires consideration of both clearance and volume distribution. So we need to know clearance at the time of prescribing. It doesn't help if I know someone's kidney function, for example, a week beforehand when they come in clinically unwell. I need to know it now. And renal function is one of the main variables that we consider. A lot of the antibiotics that we use are actually renally cleared or to a predominant extent. But for those that are not renally cleared, I'll talk to you about in a moment why that might still be important. And this is largely based on creatinine concentrations. Although there are some data which look at changes in kinetics associated with liver function, it's difficult to tease out that which is changed in volume distribution associated with the liver as opposed to clearance. And we certainly don't have any good blood tests similar to what we do in renal function, such as creatinine, which give us a measure of kidney function, of liver function. That said, creatinine itself is a very bad measurement of kidney function, but it's better than others that we have. That's for another day. And a simple example, but still quite useful. If we look at the way we normally treat people with gentamicin at single daily dosing, where we achieve a high concentration because we think that's useful, maximising the effects, and then within the 24-hour period it disappears. We know that in normal kidney function it's got a half-life of about 3 hours or less, and we can see here that we're at steady state within dosing. If we give the same dose without adjusting it to someone with impaired kidney function, for example, advanced chronic kidney disease where you've got a half-life of 30 hours, we can see that you get accumulation. So after the first dose, you get the same peak concentration, because in this case, volume distribution hasn't changed, so we still achieve what we want. But because of reduced clearance, the drug doesn't come down as far. With a repeat dose, it goes high, and we can see that we're getting fairly rapidly accumulation, and this increases the risk of toxicity. So our approach to this with decreased clearance is we decrease the dosing regimen. We still want to, the frequency. We still want to achieve the same peak concentrations. And so the general approach in clinical practice would be to increase the frequency between doses so that we can reduce the accumulation. You can see here what happens with second and third daily dosing. That makes sense, but of course, if we know that the effect of the drug is based on the peak concentration, within the same time frame, we're actually achieving high concentrations for a smaller number of times. And so that makes that as a solution suboptimal. So we saw this example before. I've put up 3 examples there of antibiotics which would go with those patterns. So macrolides we think are generally hepatically cleared and there's no renal involvement. Penicillins are proportional to kidney function, and fluoroquinolones are a combination. This is an idealised representation, and it's probably an oversimplification. If we look at some actual data, we can see here with ciprofloxacin, change in creatinine clearance. With ciprofloxacin clearance, we can see that it's approximately similar to what we would have anticipated here in terms of the change. We do see a lot of inter-individual variability around that line. So although there may be a trend, it makes it difficult for any individual patient to be able to accurately predict their clearance based on creatinine clearance. So for example here, this person has a similar ciprofloxacin clearance to this person despite markedly different creatinine clearances. So it prompts the fact that we should be thinking a bit more about titration of dosing in individual patients. Meropenem, a drug B, which is directly proportional, we can see that that works quite well. But surprisingly, when we look at something, for example here, roxithromycin, we don't see what we anticipate. Rather than it being a straight line, you get the impression that it's actually sloping down with decreased kidney function. So this would, and again, there's a lot of inter-individual variability, which makes some of the correlation line, whether that's a reasonable line to add is debated, but it questions whether or not there's another process going on. And as we're learning more, we realise that we are getting changes in non-renal function associated with advanced kidney disease. This is a study looking at fexofenadine, which has no renal clearance, and we can see in patients with end-stage renal failure, they have decreased clearance and they actually have a higher concentration in the blood. So it suggests that even patients with impaired kidney function are actually getting decreased non-renal clearance. And studies in, actually we started a bit late so I might flick over these, but essentially if you put plasma of patients with advanced kidney failure into cells, into broths, you can actually see changes in hepatocyte, also intracyte expression of different transporters. So we are getting changes in non-renal clearance based on renal failure. And this is reversible. So this is a study showing where they did an erythromycin breath test before dialysis. This is the effect that you see. Now remembering that this is looking at the effect of metabolism. So you're only breathing off the labelled carbon once it's been metabolised. So before dialysis, this is a concentration time profile following a dose of erythromycin. And then after dialysis, it's going higher. So it suggests that there's better function of enzymes in patients who've immediately after being dialysed. It suggests that there's a circulating compound which is changing clearance. So this is difficult when you've got my patients who are being dialysed 3 times a week when it comes to how do we write a dosing regimen for this individual when clearance is changing frequently, not just renal but also non-renal clearance. But this doesn't seem to work with all drugs. So for example, metformin, we know the clearance of metformin is about 3 to 5 times that of GFR, but all the clearance is due to the kidneys. And this relates to very active transporters which are actively secreting it into the kidney. And yet you can see here a rough correlation, or a pretty good correlation, but with a lot of inter-individual variability based on kidney function. Volume distribution is also important when it comes to dosing. It influences the first dose, so what concentration we need, what dose we need to give a target concentration. And I've already mentioned the fact that it can influence the time course of effect, both in terms of onset, depending on where the compartment is that you want that antibiotic to hit, and also offset if it relates to redistribution from those compartments. We've seen this already. This is important for some of the work that I do in terms of dialysis, where I'm looking at the treatment of poisoning. For example, this is a patient with dabigatran who was on regular dosing, had impaired kidney function, had a spontaneous intracerebral bleed. We decided to dialyse this patient to remove dabigatran, since at the time we didn't have an antidote. Although idarucizumab is now available, it does cost a lot of money. But back then we had nothing. And so we dialysed the patient down, we got this low concentration, and after the completion of intermittent hemodialysis, we see a rebound. And this relates to the fact that there was a lot of drug outside the compartment, the central compartment, which is what we're dialysing. We remove the drug off rapidly, then when we stop that, we get redistribution of drug from the peripheral compartment back into the blood. So if you're designing dosing studies based on dialysis before and after, and you don't look at the extent to rebound, then you might actually be overdosing people because there is a certain degree of rebound, in which case the concentration goes up. In dabigatran, sometimes it's been shown to go up by 90% from the pre-dialysis level. This depends on how much drug you were taking for how long. And the same would apply also with antibiotics. We also see that you can get a rebound after a more efficient method of dialysis. So we know that dose of dialysis is also important. This is looking at patients with valproate poisoning, whereby the concentration was decreasing. They started on a continuous, low efficiency dialysis method. And then when we gave them intermittent hemodialysis, which is much more powerful at removing the drug, it dropped it further. And then when that was stopped, again, we had a rebound. This relates to drug from the peripheral compartments coming back in. This has always prompted concern that there may be resolution of clinical effects with dialysis and then a recurrence of toxicity once we stop dialysis. And this has been particularly a question that we've asked about lithium. So for example, if we're dialysing someone with lithium, we can see the concentration comes back. And when we stop dialysis, there's a massive rebound in the concentration. But this is a study whereby they also at the same time are measuring the CSF lithium concentration. That's important because that's the main toxic compartment that we worry about with lithium. And we can see here there was no rebound, no increase in that concentration with the rebound. But these are the studies I think we need to do more of. We need to look at the effect of dialysis and how that changes the concentration in different compartments, and then in particular for things such as measuring concentrations in CSF. As a toxicologist, it's not uncommon that I'm asked a question about someone with prolonged coma who has already, it looks like the drug's being cleared and is still asleep, and the question is, does this relate to drug that's in the CSF or does this relate to some other neurological injury? And this is where if we had CSF and highly sensitive assays and also laboratories that were happy to measure these drugs in a matrix they haven't validated, it would be very clinically useful. I might flick over that in the interest of time. Lithium also raises other questions when we look at it. So this is again showing a similar picture of dialysis, drops down, rebound. If we look at that a little bit closer, we can see here there's also some differences between, depending on what blood sample you're measuring. So if you're measuring plasma samples, the concentration drops down and then it rebounds. If you're measuring if you're measuring whole blood, the concentration drops but to a lesser degree and then it rebounds. And so what we're seeing is, depending on the concentration that you're measuring, whether it be whole blood or plasma, you're getting different measurements of clearance. And so this relates to erythrocyte partitioning. And so when we're reporting the effect of dialysis, maybe we should be paying more attention to the whole blood concentration rather than just the plasma concentration. We saw this when we were looking at metformin. We can dialyse metformin and we can see that you can get marked clearances. But depending on which matrix you're looking at, whether it be plasma or blood, will depend on what results that you get. So for example, with if we look at the black circles, this relates to plasma. This is pre-filter and this is post-filter. We can see here that a lot of the drug is removed across dialysis. And as you move through the dialysis treatment, a smaller amount's being removed, but that's because there's a small amount there to take out, and in general we're removing all of the drug. But in contrast with whole blood, what we're seeing is that there is always some drug that remains trapped, and that doesn't really change. And so it's within the red cell, it's trapped within the red cell, it can't be removed during that short period of time. So then once we stop dialysing, will it come out again? The same thing would relate to rate of influx. So if I give a dose of a drug, how long does it take to get in there? And so I think this is important when we're looking at the correlation between blood and plasma concentrations, because it's going to depend in part on the timing between when the dose was taken and how long there was for the drug to equilibrate into the red cell. Just a bit more about pharmacokinetics in hospitals. So this is complicated for all of us who work in hospitals for a few reasons. Guidelines are guidelines, they're just there to help us. And most patients that we see don't really fulfill or fit with the guidelines. This is because guidelines were generally based on dosing studies in a small number of adults or volunteers, or even patients generally with stable physiology. But our patients in the hospitals generally don't have these features. They have impaired and often evolving. So I'm getting an error on the screen. Oh, you are too? I don't know how to turn that off though, because it's not on the laptop. So they've got impaired or evolving clinical organ dysfunction. Good work. Thank you. There's extremes of age, so young people or old people have changes in physiology. They may have changes in their physiological status, for example, being critically ill, or they may have specific diseases which we know change clearance or volume distribution, and that may be due to change in organ function or due to medications that we prescribe to those people. And so we find ourselves using dosing guidelines that are either wrong or at least suboptimal. And so you need some common sense in some cases to understand when these things may not apply and how to change. For example, this was a study we did looking at the dosing of meropenem in patients who are critically ill with acute kidney injury receiving continuous renal replacement therapy. You can see here, despite a doubling in the dose, there's not a clear separation between the two graphs in terms of low dose and high dose of meropenem. You can see differences in the concentration time profiles between those two patients. This was dosing based on physician decision at the time about what they thought was the best dose in view of the patient's clinical status. But we can see here the marked variability makes it difficult to give clear guidelines for individuals. We know again that comparing these two patient groups, I'm just trying to find the mouse again. Comparing these two patient groups, time after injection, with sepsis you have a lower concentration compared to what you see with patients with volunteers, which largely relates to the expanded volume distribution. You have a prolonged elimination phase, which may relate in part to the volume distribution, but also change in clearance. This is also important in terms of distribution, in that where is the infection that we're treating? Is it in the muscle or is it subcutaneous tissues? We get lower concentrations in the subcutaneous tissues than the muscles, and this is because the muscles are much more vascular in their perfusion. And again, you're seeing differences between volunteers and patients with sepsis. So it makes it difficult to make dosing guidelines which is based purely on data from volunteers. And these effects persist when you're at steady state. I thought I might also just go through a quick case that we had of showing difficulties with applying guidelines. Might have time, aren't I? So this is a man who hadn't seen any doctors, hadn't needed to, and then all of a sudden developed symptoms, was found to have advanced renal failure, came to hospital, required dialysis, and 3 days later got a line infection. So the decision was to give vancomycin. So if you look at the guidelines, generally it says that you should be giving 25 to 30 milligrams per kilo in patients in most circumstances, particularly for the first dose. And you might change the frequency of dosing if you've got decreased creatinine clearance, but otherwise the first dose should always be the same. And so this guy received that first dose. He had a very high concentration, but because he had impaired clearance, it actually took 5 days until the vancomycin came down to the usual dose. So what happened here? The person followed the guidelines as they were written. They were given a big dose and the person had a very large exposure which persisted for longer. And that's because the guidelines are largely based on a level which is at 12 hours or 24 hours, depending on the kidney function, after it being given, not at the time of being given. And we generally dose to the trough concentration. So it didn't fully apply to someone who had impaired kidney function, such as this one. But it's hard to write all of these things into every guideline. Similarly, if we wanted to use cefazolin, the current therapeutic guidelines tell us that if you've got kidney failure, which is, so for example, GFR less than 20 mils per minute, then you should be giving 0.5 to 1 gram every 12 to 24 hours. But we never do that in clinical practice. There's been about 3 studies that have shown that you can give 20 milligrams per kilo after every dialysis, or every 2 to 3 days, and they'll maintain a clinical effect. So sometimes guidelines are wrong. This makes it also hard for us to dose these things in hospitals, and these are all based on pharmacokinetics. Intraperitoneal antibiotics, international guidelines had always said we could use cefazolin or cefalothin interchangeably, and so some hospitals were using cefalothin as their baseline treatment, but our research which we performed here has actually shown that they've got very different kinetics between cefazolin and cefalothin, and actually if you use cefalothin you will not have any drug within the peritoneal space for at least 75% of the 24-hourly dosing interval, so 18 hours. That's a real concern when you're treating the infection that's there. There's also been cases where the wrong diagnosis has been made because people didn't understand about pharmacokinetics. Cefepime, maciclovir, doses weren't adjusted, patients got confused, everyone was looking for, could this be an intracerebral infection, could it relate to uremia, do MRIs, do lumbar punctures, until someone looked back at dosing and realised that if we had a dose adjusted, then that would have been avoided. So I think in each of these cases, outcomes would have been improved if there was a better appreciation of pharmacokinetics. And there's just a couple of examples, and I think we've got a lot more. So in terms of finishing, in terms of challenges, I've already shown you on a number of these cases there's marked inter-individual variability in pharmacokinetics, which complicates us using guidelines and is going to interfere with the treatment of patients or optimising treatment. So I think we really find ourselves looking at the role of measuring of drug concentrations to guide therapy so that we can individualise it. We need to consider which compartment we're measuring. And also repeated blood tests and how frequently we can do these and if that's acceptable to patients. But also ethics committees. If you put forward clinical studies that you want to do measuring these concentrations, I find increasingly ethics committees are saying no, 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 no. And so we're in the position of not knowing what to do in some cases because ethics committees have become so risk averse. I've already shown you the marked degree of inter-individual variability in terms of clearance, and that depends in part on your condition, and that just because you've got good kidney function, critically ill, you may still have the same change in antibiotic clearance. Creatinine is evolving all the time with impaired kidney function. It's changing even though your kidney function hasn't because you're getting to a new steady state, so we can't use creatinine to actually measure kidney function at this point in time in an individual patient. So I think ultimately an individual approach to dosing is required to optimise outcomes, and that's going to rely on adequate measurement of various things. Physiology, drug concentrations, but all this is easier said than done. As you know, to interpret these concentrations, you need someone to collect the blood sample at the right time, put it in the right tube, it needs to be sent to the laboratory in a timely manner. They need to write the right time on that blood form. You need to know when the drug was given exactly, not just 8 o'clock, was it 8:15, 8:30, 9 o'clock? So clinically that's not important. Pharmacokinetically it can be very important. Sample storage, increasingly pathology is looking at cost recovery. So if you want to do a study, you need to pay for sample storage. Access to assays, a lot of us don't have access to assays unless you've got colleagues or relatives who do. So that makes it difficult. And all of these things are expensive. I think guidelines are a problem, but they're the best thing that we've got. We need to start somewhere. But ultimately I think all of us will, the extent to which these things, we pay attention to pharmacokinetics in hospital practice is going to depend in part on what the local expertise is. And if you don't have expertise, you're in trouble. And sometimes experts may not agree with pharmacokinetics because they don't understand it, and then you're also in trouble. So research is important. And at a practical level, do we simplify things? I think I'll have to stop there because I'm over time. Conscious that we started a bit late, but still. So there's some conclusions, I'll just put those up there. You can have a look at them if anyone's got any questions.